Okay, thank you. Hello everyone. So today we'll have a quick recall session on what was asked in ophthalmology FMGE exam. Okay, so starting with the first question, a patient with long-standing history of diabetes presents with cataract. Which of the following metabolic pathway is primarily responsible for cataract formation in this condition? Okay, so in a diabetic patient, if we see glucose is converted into sorbitol via aldose reductase, and this sorbitol gets converted to fructose. However, in a diabetic patient, this sorbitol accumulates inside the lens, and its accumulation inside the lens is much more than its conversion into fructose. So this sorbitol which accumulates in your lens, it leads to drawing of fluid inside the lens fibers, and hence your cataract formation. See, mannitol is basically a drug that is used in acute angle closure glaucoma. Basically what this drug does is it withdraws the fluid out from your vitreous into the bloodstream, thereby decreasing your intraocular pressure. So this is not your answer. Hello? एक सेकेंड. YouTube link. Sound echo. मैं डिस्कनेक्ट करके दोबारा कनेक्ट करूं? OBS में कुछ चेंज करूं? डेस्कटॉप ऑडियो. अभी ठीक है? मैं दोबारा से कर देती. ठीक है, मेरे को बता देना अगर बीच में कोई प्रॉब्लम आती है. हेलो. ठीक है एल्स. ठीक है एल्स. अभी फिर से आ रहा है? अभी ठीक है? तो मैं स्टार्ट करती हूँ। वो कह रहे रिपीट हो रही है वॉइस। स्टॉप स्ट्रीमिंग करके दोबारा करूँ? अभी ठीक है? नहीं नहीं, कुछ भी नहीं चल रहा। अभी ठीक है? फिर से आ गई। ये किससे आ रहा है? मैं अपने हस्बैंड को एक बार बुला के पूछूं किस चीज़ से उससे आ रहा है, वो देखना पड़ता है। इससे आ रही है क्या? इस चीज़ से आ रही है। एक बार बंद हो जाए फिर शुरू हो जाए। नहीं हो रहा। इससे नहीं हो रहा, ये तो अभी आई है कॉल। दोबारा कर लिया रिस्टार्ट में भी। ये पता नहीं कहाँ से आ रही है, पता नहीं चल पा। इको भी हो रही है। अभी बैकग्राउंड में फिर थोड़ी थोड़ी आ रही है। वेब कैम वाला है होगा। अब तो नहीं आ रही। शुरू हो गई। दूसरा तो नहीं है। हाँ वो तो है, एयरपॉड्स लगा लेती हूँ मैं। हेडफोन्स भी हैं, मैं हेडफोन्स ले आती हूँ। उसमें कनेक्ट। हाँ मैं लाती हूँ एक। हेलो। हेलो। दोबारा स्टार्ट। ओबीएस 2 बार आ रहा है, 2 बार ओपन हो रखा है। इस वाले को बंद कर देते हैं। भी ठीक है। वेब कैम तो ऑन है ही है। जो ओबीएस तो मैंने एक बंद कर दिया। start virtual. Webcam on. अभी ठीक है? So in a patient of diabetes, what happens is glucose is converted to sorbitol. This happens with the help of enzyme aldose reductase, and the pathway is known as polyol pathway. This sorbitol is further converted into fructose. So what happens in diabetes, basically the uncontrolled diabetics, this sorbitol, it accumulates inside your lens and it withdraws the fluid inside your lens, right? So this sorbitol accumulates inside your lens and withdraws the fluid in the lens, which leads to the formation of cataract. Also, what happens is this sorbitol in diabetics, the accumulation of sorbitol is much more than its conversion to fructose. Okay, so this basically accumulation of sorbitol, it leads to these cataractous changes. Now if we look at other options, number A is mannitol. Now what is mannitol? It is basically a drug that is used as first line to control high intraocular pressure in patients with acute angle closure glaucoma. Okay, so what this mannitol does is it withdraws the fluid from your vitreous, thereby leading to decrease in your intraocular pressure. Then galactitol, yes, it is also responsible for cataract formation, but not specifically to diabetics. Then fructose, again, fructose is formed by conversion of sorbitol, and fructose itself directly doesn't contribute to your cataract formation. Also, they can, for the next exam, they can even ask you what is the typical type of your cataract that is formed in diabetes. So it is a snowflake type of cataract. Okay. So next question. A patient presents with right-sided field defects in both the eyes, but central vision remains unaffected. For those who have attended my class, I have drawn the diagram. So whenever a question like this comes, try to draw a diagram. Suppose this is right eye and this is your left eye. Okay, so the right-sided field defects in both the eyes. Okay, if we divide it, these would be the field defects, but the central vision remains unaffected. So our final diagram would be this. That is the central vision, that is your macula is spared, right? So what is this type of field effect known as? This is known as homonymous hemianopia with macular sparing. Right, the answer, Anmol, the answer is right. It is A. So, homonymous hemianopia with macular sparing. If you try to recall the macular sparing, on at which site of lesion does this macular sparing occurs? It occurs when the this occipital lobe is damaged with preservation of blood supply to the macula via the posterior cerebral artery. No, it's not MCA, it's your PCA that is spared. Okay, heteronymous hemianopia with central sparing, that is no visual field defect we see. Optic chiasma lesion, we see bitemporal hemianopia. Optic tract lesion, we see homonymous hemianopia, but your macula or your central vision is involved. Okay, so your answer is A. Next question. A 4-year-old unvaccinated child presents with fever, rash, and bite out spots. What is the appropriate line of management? If we look at the options, so this looks like that the child didn't get his vaccination for measles, and we know that any diarrhea or illness such as measles or your protein energy malnutrition, what it leads to? It leads to the deficient absorption of your natural vitamin A. See, vitamin A and D, they are absorbed and they are stored in the body. However, B and C, they are excreted in your urine. So, bite out spots, we know it is very characteristic. I have told you in vitamin A deficiency that bite out spots is very characteristic of your vitamin A deficiency. So in this child, even if you give vitamin A supplementation alone, the underlying problem is not treated. So in such children, management involves treatment of underlying condition, along with that vitamin A supplementation. According to the latest immunization schedule, we know that at 9 months, along with measles, we give vitamin A supplementation, right? Then at 18 months, again with your DPT booster, we again give vitamin A supplementation. Am I audible? Are you able to see my video and are you able to hear properly? And then again at 2 years, we give vitamin A supplementation. So your answer is option A. Now, if we look at the dose of vitamin A supplementation, that for a child of 0 to 6 months, the dose would be 50,000 international units. For 6 months to 1 year, it would be 1 lakh international units. These are for vitamin A. And more than 1 year, the dose becomes 2 lakhs international units. Even for an adult like you, me, the dose would be 2 lakh international units. But you need to know when it is given. It is given on day 0, day 1 and day 40. Another question, a patient presents with proptosis that increases when bending down. So when you read the question increases, that straight away clicks me to the point that the proptosis that is being caused is due to some arteriovenous, either anastomosis or maybe any vascular aneurysm that is causing proptosis, or maybe any carotidocavernous fistula that is causing this thing. Okay, if we look at the option thyroid eye disease, yes, it is responsible for proptosis. In fact, it is the most common cause of bilateral proptosis, but there is no increase in the size of proptosis that with bending. So this is ruled out. Cavernous sinus thrombosis is a complication of orbital cellulitis. However, orbital cellulitis and cavernous sinus thrombosis, the proptosis doesn't increase on bending down, right? However, if we look at orbital varices, yes, they have blood inside them. So any Valsalva maneuver or bending forward would increase the size of proptosis in orbital varices. So answer would be orbital varices. Next question, 6-year-old child presents with refractive error of -2 in the right eye and +1 in the left eye. Examination reveals normal visual acuity. See, this is very important that the child has 6/6 in both the eyes. And fundus. Even the fundus, there are no findings. Okay, what is the most likely diagnosis? If we see myopia, yes, the child has myopia only in the right eye. Hyperopia, the child has hyperopia, yes, only in left eye. Then is anisometropia and amblyopia. So what is anisometropia? Anisometropia is the difference in the refractive power of two eyes. Say one eye has 3 diopters of myopia and the other one has 4 diopters of. So this difference is known as anisometry. Okay, amblyopia. Amblyopia is the vertical suppression of one eye. So what happens in amblyopia? Either due to anisometropia or due to any media opacity, what happens is, suppose if you look here, the right eye of child has -2 diopter. Okay, so it has high refractive power, and the left eye has +1 diopter. So this anisometropia, what it would lead is, the right eye which is weaker, it will work less, and the left eye will work normally. So eventually, over a period of time, your right eye would be suppressed by your brain. This phenomena is known as amblyopia. So I know many of you would be confused between anisometropia and amblyopia. But if the child is amblyopic, then the child's visual acuity will never be 6/6. Okay, if the child has normal visual acuity, it's 6/6, then your answer would be anisometropia. Had it had the question asked that the examination reveals suboptimal visual acuity in right eye. Had the question mentioned this thing, the answer would have been amblyopia. Okay, anisometropia leads to amblyopia, but both are different diagnoses. Anisometropia leading to decrease in the visual acuity in one eye is referred to as a amblyopia. However, amblyopia can be due to other reasons such as media opacities. So, next question. A corneal whisk test was performed and the corneal reflex was elicited. Which of the following nerves is responsible for the afferent limb of this reflex? If we look at corneal reflex, what is the pathway? So as soon as you do a whisk, you try to bring a whisk near to the cornea, your eye will blink. This is what you call as corneal reflex. So we know that cornea is innervated by ophthalmic division of trigeminal nerve. This I've taught you in your cornea class. Okay, so ophthalmic division of trigeminal nerve, and the impulses will go as afferent from the ophthalmic division of trigeminal nerve into the final nuclei of the trigeminal nerve, which will send impulses to the motor nuclei of seventh cranial nerve, and this in turn, what it will do is, it will elicit the blink response by activating your orbicularis oculi muscle. We know that squeezing or closing of the eye, it is via your orbicularis oculi muscle, which is supplied by the motor nuclei of seventh cranial nerve. So your afferent will be formed by your trigeminal, but your efferent pathway, that will be formed by the facial nerve. So answer would be trigeminal. Next question. A patient sustained blunt trauma to the eye 6 months ago, now presents with the blurring of vision. What is the most likely condition? See, if we look here, this is polychoria. Now, what is polychoria? Polychoria refers to presence of more than one pupil. Okay, so this is your normal pupil. What happened here in this case was that the blunt trauma it led to the separation of iris root from its base. Normally, your iris, it is attached here, right? This is the base of iris. So when it separates, this phenomena is referred to as iridodialysis. Another phenomena which is written here is ankyloblepharon. Now what is ankyloblepharon? It refers to the formation of adhesions between the conjunctiva and the lids. Washes ring, it refers to the iris deposition of iris pigments on anterior surface of the lens. So if we look here, the lens looks almost clear. So this is also not the answer. Ankyloblepharon is not the answer. Cycloiriditis is referred to as uveitis. And I have told you, any patient with uveitis will present with pain, circumcorneal congestion, along with blurring of vision. But if we look at this eye, there is no congestion. So even this is ruled out. So your answer would be iridodialysis. Next question. A 5-month-old baby is brought by mother with complaints of the left upper lid moving up and down during breastfeeding or thumb sucking, which disappears when the baby is not being fed. I have taught you in the class, this is known as Marcus-Gunn jaw winking phenomena. Now, what is Marcus-Gunn jaw winking phenomena? It is a type of cranial nerve disinnervation disorder. So basically there is aberrant regeneration of 7th cranial nerve with the 3rd cranial nerve. Basically there is mixing up of fibers of 7th and 3rd cranial nerve. So whenever the child he eats, the impulses even go to the 3rd cranial nerve, right? And we know that 3rd cranial nerve, it's a superior division, it supplies your levator palpebrae superioris. The function of levator palpebrae superioris is elevating the upper lid. So when the child will either do breastfeeding or thumb sucking, this 7th cranial nerve will get impulses, and along with that your 3rd cranial nerve will get, which will stimulate your LPS, leading to elevation of upper lid, which is episodic. That is, it is related only with chewing or feeding of the child. So your answer is A. Next question. A patient presents with breathlessness and is diagnosed with Pancoast tumor. Now, what is Pancoast tumor? It is the tumor of apex of the lung near the first rib. So, what is present at that location? At that location, your cervical sympathetic ganglia are present. So if there is any tumor, that would basically, what it will do is it will compress your sympathetic, it will compress your cervical sympathetic ganglia, thereby disrupting the sympathetic nerve supply. So if we look at these options, anhidrosis is the absence of sweating. We know that anhidrosis sweating is sympathetic in function. So yes, it will be present. Meiosis is the constriction of pupil. We know that pupil constriction, uncontrolled pupillary constriction, it occurs due to sympathetic disruption, right? So meiosis is also present. Also your Mueller's muscle. See, this Mueller's muscle is an additional elevator of upper lid, right? So when your Mueller's muscle is affected, it will lead to the drooping of upper lid. Again, ptosis will be there. However, exophthalmos is not a feature of this tumor. See, had this tumor present in your intracorneal or extracorneal compartment of the eye, it would have led to exophthalmos. But it is present in the lung, apex of lung. So it will not lead to exophthalmos. Your answer is exophthalmos. Then a 3-year-old child presents with epiphora and probing reveals a soft block at 7 mm. So what does the soft and the hard stop or the soft and the hard block they indicate? So this soft block, it occurs whenever there is canalicular obstruction. Basically the common canalicular obstruction or your sac obstruction. If I draw the lacrimal drainage system, these are the vertical and the horizontal canaliculus. These are joined to form the common canaliculus, which goes into the lacrimal sac, and this is the nasolacrimal duct, which goes and opens into the inferior meatus of nose. Okay, so whenever there is obstruction either here or here, there will be a soft stop. However, hard stop, it occurs when your probing or syringing, when it touches the lacrimal bone, right? Okay, so what will be the best? So now what we would try to do is, since there's a soft stop, 7 mm means, that means somewhere it is at the common canal. So we'll create a extra path between the lacrimal, accessory path basically, between the lacrimal sac and the eye. So endonasal DCR, it is done when the obstruction is at the level of nasolacrimal, that is in the nose. External DCR again when it is at NLD. Dacryocystorhinostomy, this is a very vague term, right? So it includes basically all these three. However, conjunctival dacryorhinostomy would be the answer, in which we create an accessory path between the conjunctiva directly and your lacrimal sac. The cover-uncover test is performed to diagnose various eye conditions. Which of the following is not detected by this test? So your cover-uncover test, it is basically what you do in cover-uncover test. Basically, you are covering the eye. So when you cover the eye that has either squint or nystagmus, what will that eye do? That eye will deviate. See, initially, suppose the right eye of the child has, or somebody has squint or nystagmus in the right eye. So under the cover, Sorry, Vivek, I'm not able to get you. Am I not clear? Okay, so under the cover, what will happen is your eye will deviate basically to relax. And when you remove the cover, again your eye will take up the position to fixate, so that the person has binocular vision. So cover uncover test is used to detect latent squint, yes. Manifest squint, yes. Latent nystagmus, yes. However, for amblyopia, it is not detected. Amblyopia, it is detected by neutral density filter test and crowding phenomena. This question was also taught in the class. Then a patient presents with the vision problems and has history of cataract surgery. OCT finding is shown below, which is the most likely syndrome. So here what we see is your macular edema. Basically what happens is in your macular area, the fluid has accumulated after the cataract surgery. So what is the syndrome known as? I have told very like n number of times in the class. Post-cataract surgery macular edema, this syndrome is referred to as Irvine gas syndrome. Schlossman syndrome, it is a combination of glaucoma, basically acute rise of IOP, which is associated with central serous retinopathy. It never occurs after cataract surgery. It basically occurs in young males because of sympathetic over stimulation, and it is characterized by your collection of fluid in the subretinal pigment epithelium space. This red line is your retinal pigment epithelium. However, the fluid has collected above it. So again, CSR is ruled out. Elschnick pearls, it is a type of posterior capsular opacity which occurs after cataract surgery. However, it is not related to the macular edema as shown in the picture. A patient presents with eyelid crusting and gritty sensation beneath the lids, which is the most likely diagnosis. Eyelid crusting and gritty sensation. Eyelid crusting can either occur in your infections or in the long standing inflammations. Gritty sensation, it occurs because of increased blood supply. So it is a feature of conjunctivitis. See, in chronic blepharitis, you can have eyelid crusting, but there will be no gritty sensation. In dry eye syndrome, there will be no eyelid crusting. Again, in meibomian gland disease, there will be no eyelid crusting. So if you look collectively both these things, they are found in conjunctivitis. Which of these statements is correct regarding indirect ophthalmoscope? The images, I have given you a table in my last class for the differences between the direct and indirect ophthalmoscopy. So the image is erect and real? No. It is real and inverted. The condenser lens needs to be kept away from the eye. No, it is kept near to the eye. It provides 15x magnification. No, 15x magnification, it is provided by your direct ophthalmoscopy. It provides 3 to 5x magnification. Yes, this is the answer. This also, it covers an area of 8 disc diopters. Indirect ophthalmoscopy. So patient has a history of, this is a very random question and a very easy question, has a history of flying foreign body injury to the eye. Hemochromatosis is subsequently diagnosed. We know hemochromatosis is what? It is basically the accumulation of iron anywhere in the body. So ocular findings reveal iris pigmentation. See, glass and wood, they can never go to the iris, right? If they have reached till that level, that means there is a penetrating injury. So they are ruled out. Then aluminium, no, because see, everybody knows, even in medicine we read hemochromatosis is the deposition of iron. So which of these substances is most likely involved? That is answer A. So this was the end of questions. I would say hardly, I don't think even a single one was not taught in the class or in the TND. Everything was taught, and one or two questions maybe which were not taught that you could have easily ruled out. So overall, ophthalmology was very easy, but you have to just be very conceptual in ophthalmology. You just can't cram and you can think. Like when I was of your age, even I used to cram things. But everything here is like very easy and very conceptual. So I hope you all have done at least 90% of the questions correct. And I would love to get your feedback for basically the ophthalmology questions on our Telegram group, like, and what all improvements I can make in teaching ophthalmology to further students who will be preparing for the next exam. And all the very best for your results. Hoping all of you pass with flying colors. And with this, we conclude our class. Good night.